Yes.
Today we'll be dealing with Mullerian duct anomalies. Now, this is a very interesting topic, but before you go for anomalies, straight away we'll sum up about embryological development. Paired ducts derived from intermediate mesoderm, that is Mullerian duct, also called as paramesonephric duct. It is named after Muller, which was described in 1830, and depends on absence of male determining factor which is present in Y chromosome. Basically, it's a development path of human embryo which requires the absence of testosterone. So, an ambisexual period persists up to 8 weeks. Thereafter, one type of duct persists and another disappear. In ovary, the absence of testosterone inhibits the development of mesonephric duct. The atretic part remains in the form of epiphoron, pyrophoron, and Gartner's duct. In the absence of anti-Mullerian hormone, paramesonephric duct form the female internal genitalia. In 4th week of gestation, you can see in the diagram, there is a mesonephric duct which extends from the mesonephros to the cloaca, and there you have urogenital sinus. In the 5th week of gestation, a swelling on either side of dorsal mesentery on medial side of mesonephric duct form the urogenital ridge, and the medial region of this ridge differentiate into the genital ridge that from where the gonads develop. In 6th week of gestation, a longitudinal groove called Muller's groove arises from the coelomic epithelium on each side lateral to the mesonephric duct and on anterolateral surface of the urogenital ridge, and which was described in 1998 by Moore. Edges fuse to form Mullerian duct, that is also called as paramesonephric duct. Their edges approach each other and subsequently fuse. Initially, 3 recognizable regions of the paramesonephric duct are identified: a cranial vertical, horizontal portion, and a caudal vertical portion. Each segment has a distinct fate in the formation of female genital tract. The funnel-shaped cranial region of paramesonephric ducts open directly into the early peritoneal cavity. These ducts remain separated and eventually form the fallopian tubes. The horizontal region courses laterally to the Mullerian duct, crosses ventrally, and extends into a caudomedial direction. The caudal vertical region comes into contact with the paramesonephric duct from the opposite side at the median plane of the future pelvis. These paired PMDs, initially separated by a septum, fuse and form a single Y-shaped tubular structure, the Urogenital Primordium, UVP. The UVP consists of uterine segment and the vaginal segment. These give rise to uterus and the superior vagina respectively. The uterus is initially biconate, but during differentiation it undergoes a process of fusion with subsequent canalization of the intervening septum. The uterine septum regresses, may be mediated through the mechanism of apostosis, which is regulated by BCL2 gene. By 12th week, the fundus arises and the uterus assumes in a mature morphological shape. The endometrium is derived from the lining of fused Mullerian ducts, and the endometrial stroma and myometrium are derived from the adjacent mesenchyma. This entire process is completed by 22nd week of development and results in uterus, cervix, and a single uterine cavity. Now, development of the vagina and hymen. The normal vaginal development requires fusion of the component from 2 different immunological structures: the mesodermal Mullerian duct and the endodermal UGS, that is urogenital sinus. The caudal tip of UVP inserts into dorsal wall of urogenital sinus, the bladder analog, creating the Mullerian or a sinus tubercle. This process also induces the formation of sinovaginal bulb at the distal aspect of the sinus tubercle. These bulbs are pair endodermal invagination that extend as a solid core from UGS to the caudal aspect of UVP and fuse, forming the vaginal plate. The vaginal plate canalizes from the caudal aspect, then it progresses flat to form the vaginal canal. The vagina develops in third month of embryonic life. The vagina develops from two regions, that is upper third from the Mullerian duct and lower third from the vaginal plate. The precise boundaries between UVP and UGS and their individual contributions to the vagina have not been established. Some authors maintain that the superior third of the vaginal epithelium is derived from UVP and the inferior two-third is derived from UGS. Most other experts consider the entire vaginal lining to be derived from the vaginal plate of urogenital sinus. The vaginal fibromuscular wall develops from the surrounding mesenchyma. The hymen is formed by expansion of the caudal aspect of vagina with the subsequent invagination of the posterior wall of urogenital sinus. The hymen initially serves to separate the lumen of the vagina from urogenital sinus cavity until late in fetal development. It usually ruptures perinatally and remains as a thin mucous membrane. This is how diagrammatically the paramezonefric duct develop into the uterus and vagina. This is development of vagina. Now coming to Mullerian duct anomalies. Three main principles govern the practical approach to Mullerian anomalies. The Mullerian and Wolffian ducts are so closely related embryologically that Mullerian anomalies are commonly associated with anomalies of kidney and ureter. Development of gonads is separate from ducts, so normal ovaries are present in Mullerian anomalies. Mullerian anomalies may be associated with anomalies in the sex chromosome makeup of individual. Complete formation and differentiation of Mullerian duct into female reproductive system depends on completion of three phases of development as follows: organogenesis, fusion and septal resorption. Organogenesis, one or both Mullerian duct may not develop fully, so it may result in uterine anagenesis or hypoplasia or unicornate uterus. Fusion, lateral fusion, process during which lower segment of paired Mullerian duct fuse together. The uterine diadelphys or biconate or arcuate uterus can be developed if the fusion, lateral fusion does not occur. The Mullerian ducts are ordinarily pulled together by subperitoneal fibromuscular tissue. It is suggested that defect in this process may lead to malformation. The diadelphys and biconate uterus often have usually thick and strong round ligament and a tough vesicorectal fold running between the horns. Maybe that it prevents the Mullerian duct from coming together. Vertical fusion, the fusion of ascending sinovaginal bulb with descending Mullerian duct. If it fails, there is transverse vaginal septum or there may be incorporated hymen. Septal resorption. After fusion, central septum persists, later resorbs to form single uterocervical cavity. It begins at isthmus and proceeds simultaneously in both directions. That is, bidirectional theory is there. If it doesn't occur, then it results in septate uterus. Coming to incidence, in normal fertile women, it varies from 0.1 to 2%. In fertile women, it is little higher, it is 3 to 6%. And it is highest in patients with recurrent miscarriages, that is 5 to 15%. Coming to distribution of incidence, septate uterus is most common, that is 35% of the patient. Bicornate 26%, arcuate 18%, unicornate 10% and diadelphys is 8%. American Fertility Society classification, AFS classification, says that class 1 is segmental or complete agenesis of or hypoplasia. Agenesis and hypoplasia may involve vagina, cervix, fundus, tubes, or any combination of these structures. Mrk syndrome is most common example in this category. Class 2 is unicornate uterus, that is absence or incomplete development of one Mullerian duct. It is subdivided in two, with rudimentary horn, without rudimentary horn. With rudimentary horn, it may be with endometrial cavity. With endometrial cavity, it is subdivided in two, that is communicating and non-communicating, where non-communicating is more common, 66%, and communicating is 33%, and without endometrial cavity. Without rudimentary horn is another division. Class 3 is diadelphys uterus. Complete or partial duplication of the vagina, cervix, uterus characterizes this anomaly. Bicornuate uterus. Complete bicornuate uterus, where you have uterine septum that extends from the fundus to the cervical, external cervical os. Partial bicornuate uterus, septum which is located at the fundus. In both variants, the vagina and the cervix each have a single cavity. Class 5 is septate uterus. A complete or partial midline septum is present with a single uterus. Arcuate uterus, a small septate indentation is evident, not associated with renal anomalies, because it's not associated with developmental error as such, the external effect. Coming to clinical aspect, there can be menstrual symptoms, symptoms related to coitus, or symptoms related to the obstetrics. Coming to menstrual symptoms, menstrual cycle is usually normal in the majority of the patient, but if at all menstrual symptoms are to be developed, you may have menorrhagia, maybe it is due to the large bleeding surface, there may be dysmenorrhea, it may be one-sided in unicornate uterus on the side where the uterine horn is normal. Failure to control menstrual outflow by means of a single intravaginal tampon can lead to diagnosis of septate vagina or uterus diadelphys. Coital symptom, there can be dyspareunia, maybe because of the vaginal septum, or there may be bleeding again because of the vaginal septum or due to coitus, during coitus, or while insertion of the tampon. So either of these two can lead to injury to the septum. Coming to obstetric symptoms, there may be infertility. The only malformation which lowers the fertility is fully septate vagina, that is transverse. Cornal pregnancy, a rare ectopic pregnancy where implantation in the cavity of rudimentary horn. Circulation of the uterus, when circulation is sited on the line of junction of Mullerian ducts, it may be manifestation of fusion defect. Obstetric symptoms, abortion and premature labor. The increased risk of first and second trimester abortion, it is estimated that 36% of the uterine malformation has cervical insufficiency. Shorter and more distorted the uterine cavity, when the septum distorts uterine cavity unequally, more is the chance of abortion or preterm labor or placental abruption. Early abortions are more common, that is 20 to 45% of the patients. Late is in 5% of the patients, but it is controversial, not accepted by all. There may be preterm labor, placental abruption, IUGR, fetal distress, fetal death. The mechanism of abortion or premature labor, it may be because of the increased intrauterine pressure due to the decreased intrauterine space with relative cervical incompetence and a poor blood supply to the endometrium through septum. It is postulated that it may be due to reduced amount of connective tissue and higher or uncoordinated contractility due to the increased muscle content. Malpresentation of the fetus and fundal or cornal insertion of the placenta are explained by abnormality in the shape of the uterus, where subseptate or bicornate favors transverse lie, and the uterus diadelphys and unicornate uterus favors beach presentation. Insufficient uterine action. High vaginal septum can prevent cervical dilatation, but insufficient contractions are more common in third stage of labor and not in first and second stage of labor. MRP may be necessary in bicornate or a septate or subseptate uterus, and obviously the incidence of PPH is also increased in these patients. If the horns are completely separate, like you have uterus diadelphys, the expulsion action is generally good. It doesn't cause any problem. Obstructed labor. Non-pregnant horn of the uterus diadelphys enlarges during pregnancy and can obstruct labor. A vaginal septum is another cause. Other gynecological symptoms, incidence of endometriosis and PCO was high in patients with the uterine septum, as against PCO was higher in bicornate uterus. Coming to diagnosis, after going through symptoms, physical examination, then gynecological ultrasonography, MRI, HSG, laparoscopy or cystoscopy may be indicated. Coming to physical examination, the septate vagina and or septum in the vagina and two cervices can be seen on post-speculum examination directly. On PV examination, it may be possible to feel two separate uterine horns or a depression in the fundus. Uterus is unusually wide from side to side and is suggestive. This is a suggestive sign. Septate uterus can be diagnosed by passing uterine sound. Coming to imaging modalities, HSG, primary imaging modality, normal uterus and typical trigon and configuration. Diagnostic criteria, intercorneal distance, the distance between the distal end of the horn. In septate uterus, it is less than 4 cm, 2 to 3 approximately. In diadelphys, it is more than 4 cm. Normal uterus is 2 to 4 cm. It's intermediate in abdominal cavity. So, septate also you have normal between 2 to 4. Intercorneal angle formed by the most medial aspect of the two uterine hemicavities. In septate uterus, it is less than 75 degree. Bicornate uterus is above 105 degree. T-shaped uterus, hypoplastic, irregular T-shaped uterine cavity. It is because of the DES exposure intrauterine. Only anomaly in which HSG plays a significant role is DES exposure. Allows misdiagnosis between partial septate and bicornate uterus, complete septate and the uterus diadelphys. So this can be confirmed by laparoscopy. Most commonly, ultrasonography, most commonly 2D, is used to evaluate 75 to 100% of sensitivity up to 90% of specificity. Diagnose associated urological anomalies also. In hypoplasia or agenesis, absence of uterus and or cervix, it signifies agenesis. Hypoplastic uterus less than 2 cm intercorneal distance, that is hypoplasia. Unicornate uterus, difficult to differentiate from normal. Banana shaped uterus, laterally positioned. Rudimentary horn, soft tissue mass with echogenicity similar to myometrium. Obstructed horn with the functioning endometrium complex hemorrhagic cyst. Uterus diadelphys, two separate uterus with two cervix. Septate vagina. Then it is in the septate vagina, it is difficult to see. Endometrial and the myometrial zonal width are preserved. In bicornate uterus, two uterine cavity with the normal endometrium. Reliable means of distinguishing bicornate uterus from septate uterus is by either MRI or by laparoscopy and cystoscopy. Concave fundus with fundal cleft more than 1 cm, increase intercorneal distance more than 4 cm, intervening septum, echogenicity similar to myometrium, a septate uterus, convex fundal contour, intercorneal distance is 2 cm to 3 cm, intervening septum composed of muscle or fibrous tissue. Arcuate uterus may be detected. Fundal cleft less than 1 cm, clinically not significant. Death-related uterine hypoplasia diagnosed confidently by HHG. 3D USG permits accurate diagnosis, sensitivity and specificity 98.4% and 100% respectively. It is best performed during the secretory phase of the menstrual cycle so that endometrial cavity is easily outlined. The coronal plane is the most valuable in detection of the uterine anomalies. This is how it looks in 3D. Magnetic resonance imaging, MRI, it's a gold standard for diagnosing uterine anomaly. Evaluates concomitant urinary tract anomalies also. In hypoplastic uterus, absence of the uterus, cervix, upper vagina, that is oogenesis. In hypoplasia, uterus is less than 2 cm, intercorneal distance is less. Zonal differentiation is poor and the uterine cavity measures less than or equal to 6 cm. Unicornate uterus, banana or cigar shaped uterine cavity, laterally deviated, preserved zonal anatomy, rudimentary horn, soft tissue mass with the intensity similar to the myometrium, obstructed horn with the functioning endometrial distended with blood or product. Uterus diadelphys, two separated uterus and cervix, preserved zonal anatomy. Septum of low signal intensity is seen within the upper vagina. Bicornate uterus, two uterine cavity with a single cervix, preserved zonal anatomy. Concave fundus with the fundal cleft more than or equal to 1 cm. Increased intercorneal distance is more than 4 cm. Intervening septum intensity is similar to the myometrium. Septate uterus, normal shaped uterus, two separate uterine cavity, fundal segment of the septum with intensity similar to myometrium, fibrous segment with low intensity and indentation is less than 1 cm. Arcuate uterus, normal shaped uterus with a single uterine cavity, slightly concave or flat external contour. Deshpande small uterus with T-shaped cavity. Mullerian agenesis or hypoplasia, recently termed as Mullerian aplasia, absence or hypoplasia of the uterus proximal to the vagina and in some cases fallopian tubes. Two variants, partial, rare, complete, more common, that is Mrk syndrome. Coming to Mrk syndrome, congenital absence of the uterus and vagina, small rudimentary uterus may be present, normal ovarian function including ovulation. Genotypic, it is 46XX, phenotype female associated with other congenital anomalies. Usually diagnosed at puberty with complaints of primary pneumonia, age appropriate secondary sexual characters are there. Normal development of the breast, proportionate hair distribution, external genitalia. Vaginal wart can be either absent completely or short vagina can be seen. Hormonal profile is normal. Karyotyping to differentiate from male hermaphrodite if patient presents before puberty. Sonography, absence of the uterus and fallopian tube with normal ovaries. MRI, uterus and vagina is absent. Rudimentary uterus can be seen. Coexisting renal anomalies are identified. The associated anomalies with Mrk syndrome are renal, seen in 40% of the patient, ranging from complete agenesis to malposition. Usually pelvic kidney is more common or subtle. On the other side of the spectrum, you have subtle architectural alteration. Skeletal, it involves spine, limbs, ribs. These are seen in 10 to 15% of the patient. Cardiac anomalies and subclinical auditory defect can be seen. Unicornate uterus, one Mullerian duct develops normally while opposite fails to develop or develop incompletely. So There are two variants, with rudimentary horn, without rudimentary horn. With rudimentary horn, with the endometrial cavity communicating or non-communicating, and without endometrial cavity. So this is how the diagrammatic representation is there. Associated with the urological anomalies in 44% of the patients, poor fetal survival among all Mullerian anomalies because of insufficient muscular mass, decreased uterine volume, decreased ability to expand, non-communicating accessory horn having endometrial cavity most common and most clinically significant, can cause hematometra, endometriosis, ectopic pregnancy in the horn, can rupture and it has to be removed. This is how it looks like. HAG usually for the diagnosis cannot detect non-communicating horn. You can see on HAG. MRI is more reliable. Only one fallopian tube is identified. Uterine volume reduced. Accessory anomalies can be seen. UAG usually for identifying rudimentary horn can identify communicating with main uterine cavity. Laparoscopy rarely indicated. Additional IVP renal EUG should be done. This is how it looks on laparoscopy. Indication of the surgery: presence of accessory horn with endometrium. Laparoscopic hemihysterectomy of the rudimentary horn is treatment of choice. Uterine diadelphys, failure of medial fusion of two Mullerian ducts, diagnosed by two hemiuterus, two endometrial cavity, two cervices, vagina, vagina may be single or double. Each hemiuterus having one fallopian tube. Renal agenesis most commonly associated with uterine diadelphys. Simultaneous pregnancy can occur in each uterus, are always dizygotic, usually asymptomatic, non-obstructive, diagnosed during pelvic examination to cervix seen, associated with best possibility of the successful pregnancy after archaic uterus, may have a history of recurrent second trimester abortion. Unilateral vaginal obstruction can cause hematocorpus, hematometra, endometriosis, and can be overlooked as there is cyclical menstruation from the opposite side. HAG, two uterine cavity with two cervices, with two vagina, can be seen. Intercoronal distance is more than 4 cm. MRI, two widely separate uterus, two cervices, two vagina, associated renal anomaly can be identified. Indication of vaginal septum resection, obstructed unilateral hemivagina to preserve fertility. In non-obstructive vagina, surgical correction is limited, maybe in dyspareunia. Metaplastic, rarely indicated, results are disappointing. Bicoordinate uterus, incomplete fusion at the level of uterine fundus. Lower uterus and cervix are fused completely. Two separate but communicating endometrial cavities. Visualization of the uterine fundus by laparoscopy is crucial to reliably differentiate between septate and bicoordinate uterus. Important to differentiate bicoordinate uterus from the septate uterus. Different reproductive outcome and treatment strategies are there. Usually do not have reproductive associated problem, depends on length of the septum. UAG should be done in luteal phase. Endometrial echo complex is better identified, not useful for diagnosing bicoordinate uterus from septate uterus. HAG not reliable. Two chambers of the uterine cavity can be seen and septal thickness is important. MRI, two uterine body with single cervix, myometrial thickness, myometrial tissue separating two cavity has intensity identical to that of myometrium. This is how it looks like on laparoscopy. Surgery seldom required, preserved for the patient with recurrent abortion, preterm labor. Startsman-Jones metaplasty, where excision of the uterine septum is removed, cuneiform portion of the fundal myometrium and then myometrium stitch. In Brett-Tomkin metaplasty, it involves bisection of uterine uterus. This is actually in septed uterus than bicornate uterus. Now, since we are dealing with bicornate uterus, Brett Tomkin metaplasty is not done for bicornate, it is for the Strassman Jones operation. Septed uterus, failure of the resorption of medial septum after complete fusion of the Mullerian duct. So, it is most common. Subclassification depending on the septal length. Complete, that is septum up to the external os. Partial, septum doesn't extend up to the external os. In septed uterus, subclassification depending on the septal length. Complete septum, that is septum up to the cervix. Bicoordinate, bicolis. Septum extends to the external os. Approximately 25% of the patients, septum can extend into the vagina. The partial septum, a short incomplete and long incomplete. Short incomplete extends from the fundus and terminates within the body of the uterus. That is bicoordinate unicolis. Septum extends to the internal os. A longer incomplete septum extends beyond the internal os but not up to the external os. This is longer incomplete and short incomplete. Fertility is not compromised yet has poorest reproductive outcome. Once pregnant, the greater the septum, greater is the risk of miscarriage, especially in second trimester. Decreased intrauterine space for the fetal growth is the cause. Implantation of the placenta on the poorly vascularized septum is another cause. Decision to prefer surgical correction of the septum should be based on poor reproductive outcome rather than presence of septum alone. Indication for the surgery: recurrent spontaneous abortion, second trimester abortion, preterm delivery. 2 chambered uterine cavity. Length and thickness of the septum should be assessed. Laparoscopy, best for the diagnosing septate from the bicornate uterus. Normal fundal contour. MRI, normal fundal contour with the outward cavity, long single intensity of the septum. Surgical procedure: histoscopy, metaplasty with the concurrent laparoscopy. Post-operative treatment: miscarriage rates are 10% in contrast to 90% without treatment. Arcuate uterus, near complete resorption of the uterovaginal septum. It can be diagnosed by small intrauterine indentation less than 1 cm in the fundal region. Considered as a mild form of bicornate uterus, clinically it is a benign condition. HSG, single uterine cavity with the saddle-shaped fundal indentation. MRI, convex or flat contour, cavity with the broad and smooth indentation similar to myometrium. Transverse vaginal septum formed when the tissue between vaginal plate and caudal plate of the fused Mullerian duct fail to resorb. Development, or it can develop at all levels. Superior vaginal is 46%, mid vagina is 40%, inferior vagina is 14%. In neonates and infant, rarely diagnosed in neonates and infant because of the hydromycocolpos. Unlike imperforate hymen, bulging vagina is not seen with the Valsalva manner. USG is initially in initial study. MRI is more useful as it clearly defines the length of the atretic segment between the upper and lower vagina. Management is surgical excision of the septum. Post-menarche, symptoms depend on whether septum is complete or incomplete. Presents with primary amenorrhea, cyclical pelvic pain, palpable central lower abdominal or pelvic mass secondary to the hematometra, hematocolpos or hematosulfus. Local examination, no bulging membrane. The incomplete TVS allows menstrual flow to escape periodically, but hematometra, hematocolpos can later develop. The temptation to insert a needle for diagnostic purpose must be resisted to avoid the risk of converting that hematocorpus into pyocorpus. Chronic retrograde menstruation frequently result in pelvic endometriosis and adhesions which can be severe. So this is how the hematometra looks like. This is the atresia in the lower vagina. Imperforate hymen. Imperforate hymen is embryologically not of Mullerian origin, although clinically have a similar presentation. Imperforate hymen opening, where hymenal opening is not existing, will require minor surgery if it has not corrected itself by puberty to allow menstrual flow to escape. There may be cribiform or septate hymen. The presenting symptom of the imperforate hymen is surgical repair after the onset of puberty, but before menarche it is optimal. The most common scenario is that in which a young woman presents with increasing severe intermittent abdominal pain and pelvic pain due to the large hematocorpus and hematometra. This situation is preventable as a routine on examination of the genitalia can detect this obstruction and allow correction before menarche. Urinary pressure and even retention with the hydroureter and or hydronephrosis may occur due to the mass effect and resultant obstruction. Vaginal and rectal pressure is typically present. The cervical atresia, it is rare. Often breech presentation may occur more frequently than normal uterus. Usually the pregnancy takes a normal course and the delivery is spontaneous. In rare instances, non-pregnant horn of the uterus may impair the progress of the labor by obstructing the passage of the head in the pelvic cavity. With the uterus biconus uniqualis, the difficulty of diagnosis is even greater and some cases are not diagnosed until delivery. In uterus diadelphys, pregnancy may take a normal course. Occasionally, delivery may be impeded by the septum in the vagina. In the early weeks of the pregnancy, the presence of non-gravid uterus may give rise to mistaken diagnosis of extrauterine gestation. In some of the cases, menstruation may occur throughout the course of the pregnancy from the non-pregnant uterus. The pregnancy may be complicated by abortion, preterm labor, fetal growth restriction, and malpresentation. Septate uterus in some pregnancy and labor proceed normally, but sometimes repeated abortions may occur, as already seen. Malformation, malpresentation, especially breech, may be more frequent. In some cases, the placenta may be retained or adherent, and it is during the manual removal of the placenta that the condition is generally diagnosed. It is in a few cases the head or part of the fetus may pass through the septum. The uterus uniqualis, pregnancy is extremely rare in this type of uterine deformity. Pregnancy in the rudimentary horn is attended with grave risk. Increased incidence of abortion, preterm labor, IUGR, breech, presentation, uterine dysfunction in the labor and cesarean section incidence is high. Arcuate uterus, there is depression at the fundus. Fundal notching can be detected at the late pregnancy, and this may result in transverse lie. Effects of abnormality on the pregnancy. When the pregnancy occurs in the women with an abnormal uterus, the outcome depends on ability of the uterus to accommodate the growing fetus. If there is insufficient hypertrophy, the possible difficulties are abortion, premature labor, and abnormal lie. Minor defect of the structure can pose little problem. Occasionally, problems arise when a fetus is accommodated in one horn and double uterus, and the empty horn has filled the pelvic cavity, can obstruct the labor. Coming to surgical management, in vaginal oogenesis, the aim of the surgery is to create new vagina. This is that there can be surgical or non-surgical techniques. And when you create it by surgical, it is Macintosh operation. In non-surgical treatment, initial therapy, Frank in 1938 described non-surgical method to create a new vagina using sequential application of the wider and longer dilator, beginning with the dilator of 1.5 centimeter diameter and 2 to 3 centimeter length, and then gradually increasing size of the dilator. Series of graduated dilate vaginal space and it can create a functional vagina within 3 to 6 months. Another modification is Ingram bicycle seat. A patient instructed to sit on racing type of cycle seat without the seat. It's only the dilator which is placed in the place of seat for at least 2 hours per day at interval of 15 to 30 minutes, which apply pressure by leaning forward with the dilator in place. The surgical treatment without using abdominal content and with the use of abdominal content following pelvic. So when you use abdominal contents without dissecting cavity and with dissecting cavity, without dissecting cavity you have Williams operation or Vichett's operation. When the cavity is needed to be dissected between the bladder and the rectum, like Macintosh operation, you may take dermis graft or amniotic graft, or you can have flaps, that is muscular cutaneous flap, like Singapore surgery where you use neurovascular pudendal thigh flap, or fascicutaneous like labiovaginal flap. With the use of abdominal content like peritoneum or colon, when you are doing pelvic exentration, where isolated loop of colon is transported into the space created. Macintosh operation, which is most commonly done, most satisfactory results, so it is a procedure choice. 3 important principles: dissection of the adequate space between bladder and rectum, inlay split thickness skin graft, and prolonged dilatation during the contractile phase of healing. Technique: skin graft taken from the lateral side of the thigh or even amnion can be used. 0.18 inch thick, 8 to 9 centimeter wide and 16 to 20 centimeter in the length of the skin graft is taken. Skin graft is carried over the adequate size vaginal mold made up of either light plastic material or foam. New vaginal space is created between bladder and rectum till pelvic peritoneum. The mold is placed in neovagina. The edges of the graft sutured with the skin edges. This is how it is to be done. Post-operative management: bed rest in upright and flat position for 1 week. Antibiotics, low residue diet, replacing new form, new mold. The mold is removed after 7 to 10 days. Vaginal cavity irrigated with warm saline. Inspection of the cavity to determine the take-up of graft. And the new mold is applied continuously for 6 weeks, except at the time of urination and defecation. Next 12 months, new mold applied only during night. Complications: immediate injury to the bladder or rectum, post-operative infection, hemorrhage, post-operative fissure formation with a solid mold due to the pressure necrosis. That's why foam mold made up of foam is nowadays used. Failure of graft taken up, later granulation formation, contracture of the vaginal space if mold not used or coitus is not initiated. Williams vulvovaginoplasty: a U-shaped incision is taken in hairless aspect of the labia majora and sutured together to create vaginal pouch superficial to the vestibule and opening anteriorly. Once coitus begins, it gradually permits the indentation of vestibulo lengthening. Advantages: technique is simple, less local complication, early recovery, operation of choice for unsatisfactory Mackendo operation after extensive pelvic surgery or radiation therapy. Patient with a pelvic kidney where space casing is difficult. This is how it is to be done. VCT operation: an olive-shaped device placed at the vaginal opening and with the laparoscopic guidance connected to the traction device on the lower abdomen. Traction device is tightened every day, gradually pulling the olive device inward to create a vagina over about a week. But this is not FDA approved. Unicornate uterus: indication of the operation, presence of the endometrium in the accessory horn. Treatment of choice: laparoscopic hysterectomy or rudimentary horn. Surgical reconstruction procedures do not improve obstetric outcome. Uterus diadelphys: uterus diadelphys with the obstructed unilateral vagina, full excision and the malsuppration of the vaginal septum. Non-obstructed surgery rarely indicated. Recommended procedure is Strassman metaplastic, patient with the repeated poor outcome. So diadelphys and bicornate uterus, you have same. Strassman metaplastic, incision is taken in a medial side of the each hemicorpus, deep enough to enter the endometrial cavity. The incision extends from the superior aspect of each horn near the interstitial region of the fallopian tube, so to the inferior aspect of the uterus. Goal is to achieve a single endocervical canal. If two cervices are present, this unification is not recommended. The uterus is sutured. This is how it is to be done. Jones mastoplasty, it is for the septum, and the uterine septum is cut horizontally, so the bleeding is less. Tomkin, when you are doing histoscopic resection, the Tomkin doesn't come in picture. The septate uterus, it is obviously for the septate uterus, as already said. Septate uterus, indication of the surgery, recurrent spontaneous abortion, history of preterm labor. Procedure of choice: transcervical histoscopic lysis of the uterine septum with concurrent laparoscopy. Perioperative GnRH and NOAC for 2 months are given to induce the endometrial atrophy. The laparoscope is placed, histoscopy commences, and the histoscope is inserted to the level of external os. Using the operation continuously, you incise the septum by diathermy seizure or by the electrode, that is unipolar or bipolar, or by the IAC laser. It all depends on which modality you are using. You will have to use the distenting solution, and the end point is decided when both the tubular ostia are visualized and bleeding occurs from small vessels at the fundal myometrium. Main complication is uterine perforation, fluid overload, post-op management, placement of the intrauterine device for 1 month, controversial, conjugated estrogen and progesterone added to facilitate epithelialization. After 1 month, follow up with the HSG and histoscopy. Transverse vaginal septum, excision of the septum followed by vaginoplasty, depends on location and thickness of the septum. With high TBS, surgical correction is more difficult. The transverse incision made in vaginal ward, decision done between the bladder and rectum up to the cervix, lateral margin of the septum is excised, the metacarpus is drained. Pull through operation is done, or you keep the mold. This is how pull through is done. Hymenectomy, again we need not go in detail, this is how it is done. Complications of Mullerian anomalies we already seen, that is abortion, weak uterine action, postpartum hemorrhage, adhesions of the placenta, malpresentation, prolonged or obstructed labor, uterine rupture due to its poor development, and the placenta, if it is formed on the septum, may be adherent and may cause postpartum hemorrhage. So to conclude, Mullerian anomalies are morphologically diverse group of developmental disorder that involves the internal female reproductive tract. Establishing an accurate diagnosis is essential. The surgical approach for the correction of Mullerian duct anomaly is specific to the type of malformation. For the most surgical procedure, the critical test of the procedural value in the post-operative ability to have healthy sexual relations. Uterine malformation like absence, rudimentary or infantile, not amenable to treatment. Hypoplastic uterus in young girl may gradually develop with the advances of age. Excision therapy may be given. So here we complete our lecture. If you have difficulty, you can call me. Thank you. As I already said, for the septal resection, it is always better to go by hysteroscopy. And when Tompkin operation is done by laparotomy, there, because you are in midline, the bleeding is less, and you open the uterus in midline and cut the septum transversely, so that without injuring the myometrium. And that's the beauty of Tompkin. But this is for subseptic. Our convenience is bicarbonate or dihydrogen phase, you go for Strassman. बराबर आहे तो संपून किती वेळ